How can you support your team? Well, there's various different things you could do in practice, but understanding, support and standardizing care across a practice, a network or a federation, that's sometimes trickier to do. Well, in this episode, I'm going to be talking with the team from DemDX as we look at their tool that they think can really help do some of that and a few other things as we continue to tech enhance your primary care and learning. Shall we have a look? Hello EGP learners and welcome to the stream where I'm really happy to be joined by the team from DemDX as we look at something they've shown me actually for the past few months and has definitely improved over those times. I'm really happy to have them on the stream to show what they can do. I'm going to let them introduce themselves. First of all, if I pass over to Sally.
Hi, I'm Sally Johnson. I'm a GP in Woking, been practicing for nearly 30 years, God forbid. And as well as that, I've got an interest in health tech and clinical governance. I've been a medical director both in the NHS and in the private sector, and I'm working as one of the senior medical advisors with DemDX.
Awesome. That's a lot of hats and a lot of experience is definitely there, Sally. So, wow, I'm actually in awe of some of that, to be honest. And we've got Rachel as well.
Hi there, I'm Rachel Gregg. I'm the Clinical Relationship Manager at DemDX. My background is that I'm an A&E nurse. I still work clinically, but my main time is spent with DemDX.
Okay, so I guess first question I've got for you both as we go through this is, what exactly is DemDX?
So DemDX is a clinical decision support tool, essentially. So it's a piece of software that we've developed over the years to help clinicians to get to the right diagnosis and to develop a management plan. Do you want me to tell you a little bit more in detail about it? So essentially, we started about 5 years ago. Our founder, Dr. Lauren Gresser, she trained in medicine, and she initially thought she'd develop a tool to help junior doctors actually with sort of training and education. But she quickly realised there's quite a few tools out there already supporting doctor training and education. And she spotted that the workforce was rapidly diversifying and all these new roles were coming in, nurse practitioners, prescribing pharmacists, paramedic practitioners. And actually they're a slightly neglected team in terms of supervision and support for training and development. So we sort of pivoted slightly and we moved DemDX towards supporting the R's roles in primary care. So, you know, we're only GP and most of us have them now. We have nurse practitioners working alongside us. In our practice, we also have paramedics doing our home visiting. This tool is specifically really to help those clinicians. And what it does is it helps to guide them from the presenting complaint with the patient through taking a history, what to look for in an examination, gives them a range of differential diagnoses, and then helps them towards the management plan. And it's all based on NICE guidelines. So it's all, you know, safety is paramount. So everything that's in our content is based on NICE guidance. And we've also put in a whole lot of extra features. So we've got media and videos in there. So if they're listening to a patient's chest and they want to be reminded what's the difference between wheeze and creps, or they want to listen to murmurs, they can just click on the videos and see those and hear those different sounds. We've also put pictures in, you know, what would a cellulitis look like? We've got loads of little calculation tools. So your Wells scores, your fever pain scores, they're all within our tool and they will all help guide your clinician through the diagnosis. We've also gone a step further because when we took this through piloting, we noticed a lot of the nurse practitioners and paramedics, they were spending quite a bit of time making their notes. I have to confess, I think mostly those breed are better at note-taking than us GPs. And then they were wanting to do it right, but it was hugely time-consuming, which obviously slowed them down. So we've added another feature called a note builder, which means, and Rachel will demo this in a minute, they just click on the bits, the questions they're asking, it will build their notes automatically for them, and they can then put those into their clinical record. But not only does that make notes quicker to take, but it actually makes higher quality notes and it makes it easier to audit. And we've seen where we piloted this real improvement in notes audits in terms of the quality of the notes. And finally, the other features we put in is that where pathways are localized, so if a GP federation or PCN have a certain pathway for certain conditions, we localize that within DemDX for you, so you can be sure your clinicians will follow the exact pathway for your area. In a nutshell, that's what we're doing. So we're really there just to help those nurse practitioners and paramedics to work at the top of their license, to have confidence in what they're doing. And ultimately that leads to them disturbing the GPs a little bit less. And we piloted this in a number of settings and seen that basically there's less knocking on the doors of GPs for advice, or when they do ask for advice, they're better informed. They've already got the answers to the sort of questions we might throw back to them. They'll already say, oh yes, well, I've done the well score, and yes, I've done this, I've done that. And it just helps you reach a more efficient use of your supervision time.
And I guess with that, there's definitely an element of a focus on safety as well, because I guess, you know, many people probably have seen a lot of the discourse that's going on around, for example, some of the roles and the supervision requirements, and I guess the challenges that we've been seeing. I know particularly there's been things like with PAs and paramedics, like you mentioned, and stuff. But I guess this gives an element of safety into that as well, doesn't it?
Absolutely, yeah, a real element of safety, because you know that they're following nice guidance, and they're being prompted to ask the right questions and to use the right calculators and things. And I think, you know, often whenever you sort of rapidly diversify a workforce, there can be a bit of catch-up time for us as GPs as well, to understand what those clinicians can do, what their skill set is, and for them, for the clinicians to feel confident. You know, they've had all the training, they've done the textbook stuff, but this helps them when they're out there face-to-face with patients to be confident about making the right, safe decisions.
Cool. And so I guess in terms of how that works, then it probably would be useful maybe to have a look at it. Do you think that'd be a good thing to do?
Yeah, let's do that. Let's hand over to Rachel and she'll demo the product for you.
Cool.
Great.
So there we go.
Thank you very much. So this is DemDX. We'll just log in. And once we log in, we'll be brought into your homepage. So from here, there's a few other features I'll show at the end, but you can launch straight in from the homepage into a clinical assessment once you're with your patient. Once you click Start Assessment, you'll be brought into the patient information section. So you just put simply in the patient's biological sex and their age. Once you click Continue, you'll be asked on the next page what the presenting complaint of the patient is. This is to be used for undifferentiated conditions, so less for long-term chronic illness management and those that haven't yet had a sort of diagnosis. We have a long list of drop-downs that we have tried to populate with everything we could possibly sort of think of, but of course things may not show up. And what we have done for that instance is we've created a suggest a new complaint section, so that if there is something that clinicians can't find, they've written it differently to the way we might have, they can suggest that new complaint, and it'll go to our content review committee, and we can add that for them. So if I type in sore throat, one that we see a lot in primary care, and we then ask for how long has this been present, so what's the duration of the illness. So if we pop in 3 days, as we mentioned, so this is the first sort of part of our sort of safety feature of the product. So we bring our red flags right up front so that clinicians, they don't have to do anything at this stage with them, but it's just to present them nice and early. So we're always thinking about the red flag clinical features. Once you press Continue, you'll then be brought into the pathway most appropriate based on the gender, the age, and the presenting complaint and the duration. So it's brought us into the acute sore throat pathway. On this page, you'll always have your red flags there on the right that you can look at anytime. And also your note builder sits here on the right-hand side and follows you throughout your pathway. You'll see it's all structured like a normal clinical assessment. So you'll be asked some history questions. And once you click these, you'll see that in my note builder, they're being added with the prefix of history of or no history of in the history section. And if I go to the examination section, you'll have a prefix of no or presence of. So we've tried to base this on sort of the way we would expect clinicians to write their notes, often do. There's also an additional information section. These are for things that you might not want to add to your assessment or to your notes, but that it's helpful when you're doing your clinical assessment. Once you press Continue, you'll be brought into the next step of the pathway. You'll notice all the notes have carried through with you, and if at this point you want to edit them or anything, you can do, and just put some dates and things in there. And you will be able to select then which is the most appropriate step to go down. you'll know already, probably you have an idea that you've selected no to all those sort of red flag clinical features, and so that this person is probably clinically stable. But you can check either by looking at your red flags again here and checking if they don't have them, or going down in the sort of in the acute severe illness cell and checking those little red flag clinical features have all been answered no. So you can be sure that you're going down the right pathway in clinically stable. You then have a few further questions you might want to select. You don't have to, but you can add them to your notes if you so wish. And once you're happy, you'll see that any ones that I've pre-selected on previous pages have already been selected for you, so you're not having to ask those questions again. Once you press continue, you will then be brought into sort of your differentials page. They're not in any particular order. You must always use your clinical judgment with this. This isn't to be, we're not taking you down a very specific pathway. You don't have to answer all the questions. So you always have to use your clinical judgment, and we'll present you with the most sort of likely conditions that based on the presentation. We have these little short descriptions. As you know, as clinicians, time is precious. So we have tried to make it so that you can sort of scan which ones, these are the unique clinical features of these conditions, and you can scan them and see which one you think is probably the most likely to be the condition. You can open them up and go through them each feature individually. And once you're happy with the one that you've selected, you can also find that we have our calculators built into our pathways. So for example, in acute tonsillitis, we've got our fever pain score here. So we can do this whilst you're in the pathway, and it will create a score for us. And it will also allow us to add that score then directly into the notes. So we press copy to notes. It lets us know that it's going to go into our examination section. And so if I go to the examination section, I can see here that my fever pain score has been added with all the reasons why I got that score in there. Once I press continue, it will bring me to an actions page. These actions are customizable. So as Sally said, to wherever you might be working, you can make these. These ones are based on NICE guidelines, but if you have a specific pathway for your practice or your area, you can edit these and make them really like tailored and appropriate to the patients that you're seeing. If I select any of these actions, then it will be added to my management section down here and will help build those notes even further. Once I end the pathway, you'll be brought into your notes page. So here you can further edit the notes. You should always check, of course, your notes and make sure that everything's correct that you want. You can add any medical history if it's not been added, and any further management actions. This page has been set up sort of to work with those clinical systems, like whether it's EMIS or Adastra System 1, and you can copy the section. So, for example, history, and add it to the history section of your electronic healthcare record, or you can copy all and just paste it in one long note, which will bring in all of your history examination, your general information into one long note, and can be pasted directly into your clinical system. Once you press end assessment, it will remind you that at DemDX, we don't store any patient data, and all these notes, once you end assessment, will be gone. So you please make sure that they're in your clinical, in the system you want them to go to. Once you click end assessment, you'll then be brought back to the beginning and you can start another assessment. I just want to show some other features that we have. So for example, if I go through another clinical assessment, ear pain, we have added, as Sally mentioned, we've added some media. So for example, if I just fly through this section, if I go into this section, you'll see down here we've got guidelines and media. So if I click on media, you've brought what we've added is some things that might help these clinicians to, if they're not too sure what they're looking at, for example, for otitis media, they'll be able to look at these and see and do some learning as well as they're going through their clinical assessments. And also we've linked all our NICE guidelines as well in this section. The NICE guidelines also are present and accessible in the action section. So they are here, and once you click on this NICE CKS, it will bring you directly to the NICE page for otitis media. And lastly, just to show another sort of safety feature of our system, if someone was presenting, for example, with chest pain for 3 hours, the red flag clinical features are brought forward. But also what we have is if someone does select these red flag clinical features and gets to this section, has selected those, but tries to progress down a clinically stable pathway, our system will just let you know that you have selected red flag clinical features and that potentially the pathway that you're going down isn't the most appropriate one. We'll give you the opportunity to go back and reassess the pathway that you might want to go into and then progress down the one without them. And we popped actions in as well at a higher point before you get to the differential, when we, in cases where we consider that this patient is best managed not in the primary care setting but in another setting. And although you can go on and explore the differentials, we suggest that you end the pathway at this point and redirect them to another service. So that's some of the features of the system, and I hope it helps it make some more sense. If you've got any questions.
Thank you for that, Rachel. So really interesting platform, and definitely has progressed since the last time I got shown it as well. So I guess that's one thing for me to comment on. So definitely seems like you put a lot more time and investment in terms of making those flows work a lot more clearer and stuff. I guess I had a couple of questions. I know we've got some questions coming in from the chat as well. I'm just going to cover mine first, and then we'll absolutely give our viewers the opportunity to jump in. I can see some really cool questions coming in from that point of view. You mentioned about putting some of the information into the records and stuff. I guess with the way that it does that, is there any element of, I guess, coding or directly inputable notes? I guess the interoperability question comes into play here, doesn't it, with the systems and stuff and things. But how well does that work from that point of view?
So at the moment, we're not fully integrated with the electronic health records, but we are in the process of doing so. So we're in the process of fully integrating with EMIS and System 1, and then we'll do so with Adastra. So we hope that within sort of 6 months or so, it will be fully integrated. And where we are using coding, we're doing everything with SNOMED coding. So then when we're fully integrated, everything will populate and code in the correct fashion. So yeah, unfortunately, at the moment, there's a little bit of cut and pasting, but we hope within 6 months, we're going to be fully integrated.
Cool. Obviously what you showed us there was the desktop version. Is there a plans to have a mobile version that can be used? I'm guessing, again, I'm thinking those out of hours situations, those kind of environments and that kind of stuff. Or obviously we have care homes teams that go around and stuff in other environments.
Yeah. Yes, the platform can be used on a tablet, for example, which, in sort of those rapid response teams that we've thought about that might use those kind of platforms. So yeah, it is easy to use on those settings.
Cool. And I guess in terms of how it works and stuff, what I really liked was that note builder function that comes through. I mean that is a genius way, to be honest, to save time. And I know I've demonstrated other platforms recently that can absolutely help in that side of things, but the fact that it just does that alongside your discovery of the information and that safety check element that I saw you put in at the end as well, with the ability that you've actually clicked on something that may be a red flag and just reminding you, rather than stopping you, just reminding you that you put that in. I think that's a really helpful way of trying to focus on that safety element of obviously what the platform can do to help the teams and stuff and things. So yeah, just want to check that in. I guess other questions that we always ask on the stream and stuff. So I guess in terms of onboarding time, if a practice or an area did want to look at onboarding with DemDX and stuff, what kind of timeframes are they looking at for that to happen from the practice team's perspective?
It's a really quite an easy and simple process in terms of onboarding. The training is, like, as you can see, it's pretty simplistic, and it is just a web-based software. It is simple and easy. The one thing is the actions customization. Of course, if practices don't want to use the sort of set CKS actions that we've created, that would take some collaboration and work with practices to make sure that we get that done. But it is a relatively quick and seamless implementation.
Typically we probably say from initial contact, it takes about 3 months for us to meet with you, talk you through it, customize it how you want it done. We then provide, Rachel's underselling herself there. She provides face-to-face and sort of virtual training to individuals if necessary, or to groups. So we've got a real sort of network of support around them. And once we've gone live over those first few weeks, there's always somebody available. If anybody gets stuck on it, any clinician gets stuck or needs help, they can just contact one of us directly. So, yes, it's very intuitive and easy to use, but there'll be some people that find tech a bit harder. And so we've got the support around them to give time and support in real time when they're using it. And to put some context there, we've launched already in a number of settings. So we've run in sort of GP extended hours hubs. We're currently, as we've said, doing a big project with Bromley by Bow, working with their ARS roles. We're working with community pharmacists and GPs in Essex to help the GPs to direct patients to their community pharmacy scheme, where the pharmacists themselves are using this tool to help them with their consultations. We've worked with custody suites, so where primary care is being run in custody suites in police settings, and we've worked in sort of community rapid response settings. So we've got lots of experience supporting teams to launch this product in their particular sort of situation.
Cool. And I guess with that, the way that the tool works, I could see some people, thinking, could this be used, for example, as a triage type tool? And my understanding is that that's not really what it's designed for. But I guess keen to get your opinions on, would that work?
No. It's not designed to be a triage tool. I do believe triage tools are a totally different beast. That's about identifying the seriousness and the acuteness of something, and then which person or which part sort of workforce they should be navigated to. This is actually this consultation support tool. So it's when you've got your patient and you've got a qualified clinician seeing them. It's not to be used by administrators. The only caveat to that is we've developed an additional module to be used by receptionists in our community pharmacy scheme. So there, when the patient rings in, the receptionists are using a different part of DemDX to ask a few key questions to make sure if they're suitable to be redirected to pharmacy. And then that bit of information will be sent over to the community pharmacist, and the pharmacist themselves then uses DemDX to do their consultation. And all that information will come back to the GP record. So we're really excited by this sort of launch out into the community pharmacy scheme as well.
Cool. And in terms of cost, so how much would this cost for, I guess, a practice, a network, a larger footprint, for example?
So unfortunately, neither of us are from the sales team. Each cost is discussed in detail with the providers, and it depends on the need. What we're not is, it's not sort of cost per user. So we don't say you've got 10 GPs, so it's 10 times X. What we have a look at is the size of your service, because we don't want you to be restricted and go, oh, we've got 11 nurse practitioners on today, so somebody's going to get kicked off. We haven't got enough licenses. We don't do that. We look at the size of your service, and then we find a cost that works with the provider. We want this to be used, obviously. We're passionate about it. So we're going to make sure that it's attractive to providers, and that they can see the benefits in the time saved in terms of GP interruptions, and also in the quality of the work that their ARS roles are doing for them.
Could you give us, I guess, an example, if that's all right?
I'm really sorry. I don't have, Rachel, I don't have anything to do with the finance side. Apologies, but we can get that out probably in the chat later.
Sure.
Yeah, I was going to say in the chat, Lauren might be able to answer.
No problem. Okay. I know we've had some questions in the chat and stuff. I guess one I'm going to cover really quickly, because it looks like it was missed from earlier, and that's from Mark McCartney about how well does it integrate with EMIS and System 1. From what I heard you say, this is in the plan. It doesn't directly integrate at this point, but there is absolutely that copy and paste feature that can make some of that workload easier rather than having to type it all out and stuff and things, which looked really good. Yeah,
but hoping to integrate within a matter of months.
Cool. Okay. So Anna's asked a couple of questions. One in particular looks very interesting. Do you have to consent the patient before use? So an interesting one there.
No, we're not storing any patient information in this database at all. So it's there. It's a support tool. Much as if you had a look at your NICE CKS site when you're with the patient, that doesn't involve patient consent. So it's supporting the clinician. It doesn't need the patient consent.
Cool. And then she mentioned about does it include safety netting advice? So I saw there was that management kind of section and stuff. Could you expand on that a little bit more for us?
Yeah, so and sometimes it's fairly generic, make sure you provide safety netting advice. In other situations, we give examples of what we mean by that, especially if there's something that's quite tailored to a certain condition. And especially with safeguarding things, we talk in a bit more detail about what sort of safety netting you need to do. So it'll always be there. We'll always prompt them to remind them. And in some cases, it will be detailed specific safety netting advice. And again, this can be customized. So if actually you feel that this is an area where your clinicians maybe struggle with safety netting, then we can customize your action boxes to put in whatever detailed safety netting advice you want us to add.
And I guess with that, does that change, I guess, over time in terms of the personalizations and stuff? And I guess from your point of view, what kind of process would practice have to go? I guess things always change in general practice, don't they? Pathways change, routes change, that kind of stuff. I guess if something was to happen, what kind of timeframes are they looking at for that to be actioned?
Yeah, so internally we have a clinical reference group, which is a mixture of our own internal doctors and nurse practitioners and independent doctors and nurse practitioners, and we meet quarterly to review all of our content and to make sure that any new NICE guidance is integrated into the tool. If any NICE guidance comes out in the interim, which is actually urgent, then we will change it. We'll have a virtual meeting of our group and change it more rapidly. We wouldn't wait until 3 months up if some massive change came out in the NICE guidance.
Mm-hmm.
We have a feature, we work closely with the sort of clinical directors of our providers. If they contact us and say, actually, our pathways change, we need to get it changed quite rapidly, we would arrange for that to be done in a matter of hours or days. It's very straightforward. But we also have a tool within there that if a user just picks up on something and just wants to make a suggestion to us, that can come through to us and that will be shared with our clinical reference group. So if a user says, oh, well, I've spotted you suggested doing X and I've always tried doing Y, we would take that to our clinical reference group to see whether or not we want to review the content that we've got published.
Mm-hmm. And I guess if it's more simpler kind of change, like just a change of name of where things go, like you mentioned within the practice, I guess, if it was normally you send it to the Mosaic service, which is your MSK thing, and they've changed the name of that, that would clearly be a lot quicker to change, I would imagine, than having to go through that process and stuff.
Yeah, that would be done in real time, and we're developing the functionality so that the clinical directors or the management team of the provider service can change things like that themselves. Obviously, we want them changing clinical content, but things like phone numbers, referral points, that sort of thing, they will be able to change themselves.
Okay, cool. And Mark's given us a couple more questions. I guess one I'm probably going to answer for you, if that's all right. So he's asking, how does it advice recorded on the EMR? So from what we saw, it's not directly recorded in the EMR directly. At this point, it's using the web app, but obviously that's one of the hopes I think that you said that you've got in terms of more integrated things that will happen in the next few months. Correct in saying that, Anzo?
Yeah, absolutely. So it will copy and paste over the advice that they've tipped that they're going to follow. They can copy and paste it into their EMR, but it won't be fully integrated yet.
Sure. And if you have just joined us, feel free to go back and watch that bit again at the start if you want to. However, more specific question we've had from Mark is there a specific safeguarding module, i.e. tools for checking capacity, awareness, I guess, and other kind of elements along those lines?
We haven't actually. That's an interesting point. Something we'll take away to look at as development. Obviously, we have sections on safeguarding, especially the sorts of presentations where they should be considering safeguarding risks, and we link them through to the NICE guidance on managing safeguarding concerns. But absolutely, that's something we can look at. Should we put mental capacity assessments within there, and what other tools can we put in to make the safeguarding section more robust? That's something we'll take away.
Mm-hmm. And as you showed, there are some interesting tools already built into that. So obviously the calculators and that kind of stuff that exist. And I really like the media section, actually. That was quite cool in terms of being able to demonstrate, not just, I guess, for the clinician's awareness, but I could also see that being used with the patient as well during the consultation. To actually, sometimes you're there Googling, the structure of the ear, so you can show the patient this is where your actual problem is, and actually click of a button, you can show that directly, and also what you're seeing compared to what may be there, or vice versa, and that kind of stuff.
I think that's what we've really tried to do, is try to bring in all the different elements that you might open as a clinician when you're with a patient. So whether that's NICE CKS, your MD Calc, or Googling the media, so that it's all in one place, so that those sort of R roles and people joining aren't having to go to 5 different places to five different things, and it's really just trying to get so they can focus on the clinical assessment and the patient that's sitting in front of them.
And I know, although the focus seems to have been more on the R's roles, I can definitely see this applicable, for example, for our GP trainees, F2 doctors, med students, all that kind of stuff as well, because actually a lot of what's covered there is the things that we would facilitate them with throughout consultation as they go on their training journey. But also, to be honest, even in a tutorial capacity, you've now got that ability to structure that learning, and to be honest, not have to go find all the media for it at the very least and stuff.
And that's an interesting point, because we've also putting in a module, developing a module to help with CPD, and so this can be used for training either within sort of tutorials or supervision sessions, or for the clinician to go away and do things on their own. And what it'll do is it'll capture all the data on the pathways they've done, the media they've looked at, and that'll be captured in a way that they can then just take that over and import it into their annual appraisals or revalidation. So that's all going to be coming soon as well, a really good log of CPD whilst using the platform.
Awesome. Cool. So thank you both of you for joining us for this live stream. I know we've had some really good questions there and some really good content that I've seen. Like I said, I love the way that you build the notes as you go across with that learner's kind of journey in terms of what they're exploring with the patients, in terms of the history that's developing and their findings and stuff like that. I think is absolutely awesome. And as ever, I love extra media stuff in there. So that I think is quite cool, like I said, and particularly the learning experience, not only for the individual clinician, but also the patient's perspective and stuff and things. I think that's really awesome. I guess if people were interested in looking at DemDX, where would you recommend that they go?
We have a contact section of our DemDX website. So if the link is on the screen now, if you go to that, we have a little form you can fill out and get in touch, and we'll get back to you with any questions you have. Love to.
Yeah, and if you just look at the website, so just demdx.com, it's got loads more information about what we can offer and what the service can do for you as well.
Definitely. And if people are watching this on the replay and stuff, if you check in the show notes, I'll put a direct hyperlink into that page and stuff, so you can get there directly from there. I know that you guys were really busy at the Best Practice Conference, where we're just recording shortly after that stuff. So I know there's definitely been a lot of interest, and I hope that people do have a look at it, because I think it's quite cool as well. As ever, if people do have any other further questions they want to ask, let me know. I'm more than happy to try and signpost and direct, or if not, we can pass those on to the team as well. And as always, we're going to be here to help tech enhance your primary care and learning. We will catch you in the next episode.